The next session I'd like to introduce is going to be delivered by Dr. Ron Perrone. He's the Scientific Director of the Clinical and Translational Research Center of Tufts Medical Center and Professor of Medicine at Tufts University from Boston. And the title of his talk will be on what do clinicians need to know about management of ADPKD in 2019. Thank you, Ron.
Thank you, Yuri. Thank you very much for inviting me to speak at this wonderful conference. These are my disclosures. So the goals and objectives are to review the natural history of ADPKD, including renal and extrarenal complications, to review the use of total kidney volume as a prognostic marker for ADPKD, and to review the management goals for general nephrologists, including blood pressure control and ESRD care. So I'll emphasize or re-emphasize some of the things that Dr. Watnick mentioned. Obviously, ADPKD is a hereditary systemic disease with bilateral kidney cyst, progressive decline in GFR leading to kidney failure in about half of the patients by the 6th decade, extrarenal manifestations including cyst and extracellular matrix abnormalities such as cardiac valvular defects and brain aneurysms. And then, not to forget, all of the issues associated with chronic kidney disease as GFR declines. So anemia, metabolic bone disease, nutritional issues, and increased cardiovascular risk. This is a slightly different version of the microdissection studies that Dr. Watnick showed. The point is that cysts start out as focal microcysts in only small numbers of cells throughout the nephron. Cysts grow due to cell proliferation, abnormal extracellular matrix, and fluid secretion. And cysts separate from the parent nephron at about 2 millimeters of size, and at that point, secretion takes on a larger role. This is a slide courtesy of Tai Bei, who is a radiologist who develops the imaging methods used in the CRISP study. And it illustrates MRI of 4 different patients at different stages of the disease. In the T2 phase of the MRI, cysts are white because they contain water, and parenchyma is dark. And this is an earlier patient, and these other patients show a more advanced form of the disease. And the features that are notable include the fact that the kidneys are getting larger over time, and the cysts replace most of the normal parenchyma. On the right side are the same kidneys shown in the T1 phase of the MRI, and in these patients, gadolinium contrast was used. We don't need to use gadolinium contrast for assessment of kidney volume, and we no longer use it routinely. And again, cysts are black, parenchyma with contrast is white, and this similarly illustrates the progressive growth of kidneys and the replacement of the parenchyma by cysts. So the kidney manifestations of ADPKD are well known to you, any of the clinicians who take care of PKD patients. So cysts scattered throughout the kidneys, an inexorable increase in total kidney volume, leading to painful and palpable kidneys, progressive loss of kidney function, hypertension, intermittent hematuria, cyst infection, pyelonephritis, nephrolithiasis, and impaired concentrating ability. And the outcome toward end-stage renal disease is nicely illustrated by this study from Hematuria et al., which looks at renal survival, which means time to ESRD, meaning either dialysis or transplant, in patients with the PKD1 or PKD2 mutation. And as Dr. Watnick explained, it's in smaller numbers of patients, there are other genes that are mutated. But the median age of ESRD is about 54 in PKD1 and about 74 in PKD2. PKD2 tends to progress more slowly, smaller kidney volume at any age. The growth in kidney volume was captured beautifully in the first publication of the CRISP study. It's a consortium devoted to radiological imaging in PKD. This was an observational cohort. This is the first publication showing the growth in kidney volume, and this cohort has been followed, I think, now up to 13 or 14 years. But it illustrates nicely that, again, this is observational. Kidneys grow in an exponential fashion. This 18-year-old young man had actually fairly remarkable growth in his kidneys over a 3-year period. Growth occurs in both women and men. And notably, during this 3-year study, GFR declined by 4.3 mLs per minute only in those with the largest kidneys, that is, kidney volume greater than 1,500 ml, which is about 5 times the size of 2 normal kidneys. This has been refined further through additional studies, including additional work by the CRISP group. I'll take you through the PKD Outcomes Consortium work. This consortium obtained data from 4 different sources of 4 different registries and studies, so Emory, Mayo, University of Colorado, and CRISP. And these patients all had at least one measurement of total kidney volume and then long-term follow-up of kidney function and whether or not they developed ESRD. And these data were consolidated using common data elements. They were put into a database called the Study Data Tabulation Model, which is important for regulatory submissions. And we ended up with over 2,300 individuals who had at least one measurement of kidney volume and longitudinal follow-up. And I'm just going to show you a snapshot of the data. So the outcome we looked at was whether kidney volume was associated with a 30% decline in eGFR, which is now a measure which is accepted by regulatory agencies, including the US FDA, and I also believe Health Canada accepts this. And if you just dichotomize the group into kidney volume less than 1,000 or greater than 1,000, you can see that irrespective of the age or the GFR, so for example, the bottom panel shows those with GFR greater than 50, and younger than 40 or older than 40, having a larger kidney volume predicts a greater likelihood of developing a 30% decline in eGFR. Similarly, if you have a GFR below 50, and again, younger individual, less than 40, older than 40, total kidney volume separates and larger kidneys are predictive of a greater likelihood of developing a 30% decline in eGFR. And total kidney volume was qualified as a prognostic enrichment biomarker by regulatory agencies in Europe and in the United States. And this allows pharmaceutical sponsors to use total kidney volume to select patients for clinical trials because the regulatory agencies accept this. And these references are included in your syllabus if you want to go into this in more detail. So the use of total kidney volume was further refined by the work of the CRISP consortium and Drs. Arazabal and Torres, and this resulted in the Mayo imaging classification. And let me take you through this. So in this graph, kidney volume is divided by height to account for differences in body size. So height-corrected total kidney volume is employed. And these were the measurements of height-corrected kidney volume as a function of age. And the way to think about this, if your kidneys are big at a young age, as in these group of patients here, it means they grew more quickly. Whereas if your kidneys are small at an older age, it means the rate of kidney growth is slower. So this is a way of looking at kidney growth. And the Erasmus classification, or the Mayo classification, broke this down into 6 groups reflecting these rates of growth of kidneys. So from less than 1.5% per year to more than 6% per year. And these were translated into, in this population, into rates of GFR decline based on the class. So for example, if you have class 1E, you have a much more rapid rate of loss of GFR as compared to class B or 1A. It's important to note that this only applies to typical ADPKD, where you have cysts scattered throughout both kidneys. I don't have time to go through the variations. I think Dr. Torres will reflect on some of this in his talk later on. So when you see a patient in the office, I think it's important to go through this schematic in terms of how you think about the patient and how you will approach them in terms of offering treatment options. So obviously, you have cysts, you confirm the ADPKD diagnosis, which can usually be done by ultrasound imaging. And then you look more closely and determine whether they have typical or atypical ADPKD, depending on the cyst distribution. And I favor assessing kidney volume using more comprehensive imaging techniques such as a CT or an MRI. And this can be used to assess the total kidney volume. And this can easily be done using the ellipsoid method. And there is an online calculator that uses the Mayo classification that derives from the ellipsoid technique. And just, if your radiologist can't do a full stereologic assessment of kidney volume, then just measuring length, width, and depth will allow you to do this calculation. So assess total kidney volume corrected for height, assess whether it's Mayo class 1C, 1D, or 1E. If they're older than 18 years of age and their eGFR is greater than 25, you can consider a disease-modifying treatment. And Dr. Torres will be talking about this in more detail. If they're Mayo class 1A or 1B, or if they have atypical ADPKD, such as unilateral, asymmetric, or with parenchymal atrophy, you can implement monitoring and then these basic optimized ADPKD management measures, which I will talk about in more detail. But this will focus on blood pressure control, maintaining a dilute urine as a result of suppression of vasopressin by fluid intake, reducing osmolar intake, and I'll focus on caloric intake. So let me take you through some patient examples. Patient number 1 is a 33-year-old female. She's newly diagnosed. She does not have hypertension. Her GFR is almost normal. It's 89 mLs per minute per 1.73 meters squared. And she has a strong family history for ADPKD. Her paternal grandfather died at age 39 with hypertension, was not formally diagnosed. Her father had classic ADPKD with ESRD at the age of 51. He had a preemptive kidney transplant, and she has a sister with ADPKD and hypertension. And her symptoms were polyuria and enuresis. So her ultrasound shows perhaps the background, it's probably easier to see on these other screens, typical appearance of multiple cysts scattered throughout both kidneys. Left kidney is slightly enlarged. And when you look at her kidneys by MRI, it's obviously very easy to make this diagnosis and very easy to estimate her kidney size. And in this case, her total kidney volume was 495 cc's, She fell into Mayo Class 1B. So what do we tell her to do? Well, the first thing we tell her to do is to drink a lot of water, because we know that vasopressin is involved in worsening of cystogenesis. Again, Dr. Torres will focus on tolvaptan, but whether you inhibit vasopressin directly or whether you inhibit it through maintaining vigorous hydration, this results in preclinical models in reduction in cystogenesis. And if you knock out the vasopressin or eliminate the vasopressin gene, even though you have PKD, these are rat models of PKD, you have very effective amelioration of cystogenesis. So the goals then of high water intake, this is in the absence of treatment with tolvaptan, is to reduce urine osmolality below 280 or to decrease urine osmolality by at least 300 from baseline. And this requires a large intake of water, at least 3 liters per day. It's important to be aware that urine output is also affected by solute intake. So if you have a large solute intake, typically through salt and protein, you have a lot of osmoles to get rid of, and it's hard to maintain a dilute urine with a large osmolar intake. And typically you would avoid high water intake in individuals who are at risk of hyponatremia. So these would typically be those with a GFR below 30, those who are on thiazide diuretics, and those who already are hyponatremic. Dr. Watnick illustrated nicely the many metabolic issues associated with ADPKD. In HALT PKD Study A, where we measured total kidney volume throughout the study, obesity and overweight were associated with faster total kidney volume growth and eGFR slope decline. This slide shows the impact of normal weight, overweight, or obesity on the annual percentage increase in total kidney volume. And in the HALT study, even individuals with normal weight had a rate of kidney volume increase of more than 5% per year, but the obese individuals had a larger increase in the rate of total kidney volume growth, and this was associated with worse outcomes. Further, if you restrict calories in rodent models of PKD, and again, Dr. Watnick showed this evidence in great detail, this decreases cystogenesis. So there's many reasons to maintain a normal body weight and to lower caloric intake in PKD, including reduced cardiovascular risk. The CRISP study and the HALT study investigated the effect of dietary sodium on PKD progression. So in the CRISP study, average dietary sodium was 4.3 grams and was associated with increase in TKV over time. In the HALT study, the average dietary sodium intake was 4.1 grams, and in study A, it was significantly associated with the rate of total kidney volume increase and eGFR decline. In study B, it was associated with the increased risk of the composite endpoint of 50% eGFR decline, ESRD, or death. And notably, despite being followed by major centers who were expert in taking care of patients with polycystic kidney disease, we didn't succeed at a large reduction in sodium intake. So this is hard to do, but I think it's important that you work on this with your patients. Second patient is more advanced. She has larger kidneys, Mayo Class 1C. She has hypertension. Her GFR is 61, which is almost in stage 3 CKD. Family history is unknown, and her major symptom was fatigue. So the HALT study took advantage of the known activation of the renin-angiotensin system in PKD, where you can think of ADPKD is a model of bilateral renal artery stenosis, where cysts compress arterioles, resulting in increased renin, increased angiotensin II. The direct effect of angiotensin II to increase vascular resistance and also to stimulate aldosterone, resulting in renal sodium retention. Both produce hypertension. Further, angiotensin II has direct effects to increase fibrosis and increase mitogenesis. The HALT study had two interventions. HALT study A had two interventions, intensive blood pressure control and combined ACE and ARB together. And the intensive blood pressure control, that is less than 110/75, in hypertensive individuals who were younger, the ages 18 to 50, with preserved eGFR greater than 60, was well tolerated and safe, and slowed the rate of growth of kidneys by 14.2% over 5 years, reduced left ventricular mass index, reduced urinary albumin excretion and renal vascular resistance, and there was a borderline benefit on eGFR progression. Secondary analyses of this population revealed a greater benefit in Mayo Class 1D and 1E, with slower total kidney volume growth and slower eGFR decline. There was no benefit of combined ACE-ARB. In study B, the treatment goal was eGFR less than 60, was 130/85, and there was no intensive arm because of the concern that combined ACE and ARB would result in complications of AKI and hyperkalemia, particularly in those with lower GFR, that is GFR less than 60. So the preferred order of treatment of blood pressure agents would be ACE or ARB, followed by an alpha, beta, or cardioselective beta blocker, dihydropyridine calcium channel blocker, with diuretics being third or fourth line therapy. Patient number 3 is a 38-year-old male who has hypertension. As you can see in this CT scan, his kidneys were quite large. This was done with iodinated contrast. And you can see very little parenchyma. These kidneys are mostly cysts. Here's evidence of cyst hemorrhage. And this individual had such severe pain and recurrent hemorrhage that he underwent a left nephrectomy. He had a very clear family history of ADPKD with ESRD in his father at age 68 who had a preemptive transplant. So because of this recurrent gross hematuria and pain, he had a laparoscopic left nephrectomy at age 38. So cyst hemorrhage occurs in about 60% of individuals. It can be gross or microscopic if the cyst connects to the collecting system, and you can also get intracyst or subcapsular hemorrhage without hematuria. And the cyst hemorrhage is thought to result from excessive angiogenesis that results in fragile blood vessels. If you can imagine these blood vessels stretched over the walls of enlarging cysts. So very susceptible to trauma with resultant hemorrhage. And we know that patients with recurrent episodes of gross hematuria have the largest kidneys and progress more quickly to kidney failure. So minimize trauma in those with enlarged kidneys. Pain is very common in ADPKD, about 60% during the lifetime. You can get acute pain or chronic pain. Acute pain is typically a result of an event such as a cyst infection, cyst rupture with or without hemorrhage, torsion, nephrolithiasis, or obstruction. You also need to consider whether there's infection, rupture, or hemorrhage of a hepatic cyst, particularly in someone with an enlarged liver. Chronic pain is typically a result of cyst expansion, stretching of the renal capsule, or enlargement of the cystic kidneys and compression of other intra-abdominal structures. And finally, in people with very large kidneys, they can get musculoskeletal back pain, so related to this exaggerated lumbar lordosis due to increased abdominal girth resulting from enlarged cystic kidneys. Urinary tract infection, a common complication of ADPKD, affecting 30 to 50% of individuals, more common in women than men. Important to have your suspicions high for cyst infection because this requires a longer course of antibiotics. Typical symptoms would be fever, flank or abdominal pain, malaise, and other constitutional symptoms. The finding of a positive blood culture in the absence of a positive urine culture would be strongly suggestive of a cyst infection rather than pyelo. This requires lipophilic antibiotics such as the quinolones, trimethoprim. We rarely use chloramphenicol. And some of the third and fourth generation cephalosporins can also be used. One obviously needs to be concerned about antibiotic resistance, and if you have a specific pathogen that you can identify, that's so much the better. In refractory infection, drainage of cysts must be done, but not typically required if someone is responding well to antibiotics. And localization may be difficult, particularly in a large kidney with multiple cysts, and PET CT scan may be helpful in terms of localization. There are many quality of life issues related to large cystic organs. Some patients have substantial enlargement of the abdomen, chronic pain and discomfort, and surveys and focus groups of patients with PKD reveal many concerns about body image. Obviously, these large kidneys and/or liver can result in sleep disturbance, and one needs to be careful about using seat belts because of increased kidney pain. This would be the rogues gallery of very advanced enlarged abdomens. Dr. Grantham shared these images with me. So these are some of the bellies that people with ADPKD may experience, and these were some very large kidneys which led to this abdominal enlargement in this individual. Patient number 4 is a 41-year-old female who did not have hypertension, reasonably well-preserved GFR. Her family history was notable for a daughter with liver cysts and a mother with kidney cysts. And she had disabling left upper quadrant stabbing pain with abdominal bloating. And she had genetic testing which revealed ADPKD2. It's worth mentioning, this is all cystic liver shown in the T2 MRI. So very prominent cystic involvement. This is another patient exhibiting a very large cystic liver in a person who's undergoing partial hepatectomy. So hepatic and pancreatic cysts are probably the most common extrarenal manifestation of ADPKD. These are asymptomatic in many patients, but can expand and cause pain and abdominal distension and infection, typically worse in females and rarely massive PLD. You want to avoid exogenous estrogens because estrogen makes the PLD worse, and you could consider off-label somatostatin, that is octreotide, for very severe PLD for symptomatic relief. Cardiac valvular abnormalities, typically mitral, tricuspid, and aortic valvular prolapse and regurgitation. Rare patients have dilated cardiomyopathy, typically associated with PKD2. Intracranial aneurysms are also found, as Dr. Watnick mentioned, about 10% of patients on average with PKD will be found to have an aneurysm. Typically, they're found in 5% of patients with no family history and about almost a quarter of patients who have a family history of intracranial aneurysm or subarachnoid hemorrhage. The risk of rupture depends on size and location. We know that smoking, uncontrolled hypertension, and excessive alcohol use can increase the rupture rate. So typically we screen those with a positive family history, those with high-risk occupations, and those who request. So some patients find it important for them to know whether or not they have an aneurysm. Seminal vesicle cysts are fairly common in men with an undefined risk of infertility. Typically, we don't think of ADPKD as a disease associated with infertility, but nonetheless, we find couples, men and women, showing up in infertility clinics with ADPKD. So the optimal management in CKD4, so with an eGFR below 20, should include optimizing cardiovascular and overall health, preparing for kidney replacement therapy, managing complications. And the preferred modality for ESRD would be preemptive live donor transplant and appropriate preparation and anticipation of that. The choice of modality for ESRD is important. First, we know that survival after ESRD is better than the general ESRD population, even when you exclude diabetics from the control population. Peritoneal dialysis, been used extensively in ADPKD and has a high success rate. There are issues with hernias, with large kidneys and liver, and diverticulitis. In Hong Kong, PD is the primary modality for all patients with ESRD, and there are a number of studies which demonstrate very good outcomes in PKD patients. Regarding hemodialysis, there are issues of anticoagulation and cyst bleeds that must be addressed. It's important to recognize that the mortality from extrarenal issues is far less than that due to cardiovascular disease. So I tell my patients, you're much more likely to have a heart attack than you are to have a PKD complication later on in your disease. So cardiovascular health is very important. And we know that transplant outcomes are similar to other patient groups. Regarding nephrectomy, this is a statement from the KDIGO Controversies Conference held in several years ago, that kidneys should not be routinely removed prior to transplantation, as nephrectomy in ADPKD patients is associated with significant morbidity and mortality. And the slide lists the indications for nephrectomy, such as recurrent and/or severe infection, symptomatic stones, recurrent or severe bleed, intractable pain, suspicion of cancer, and space limitations prior to transplant. The space limitation prior to transplant is not objectively defined, and most patients don't need polycystic kidneys removed to make space for the transplant. And we know that kidneys decrease in size after kidney transplant. This is a study from Japan showing a 37% decrease in total kidney volume by 1 year post-transplant. So the different ways to approach this, we generally want to avoid pre-transplant nephrectomy because this will preclude preemptive transplant because of the loss of GFR, and as mentioned, for recurrent infection, bleeding, or malignancy. Simultaneous nephrectomy and transplant is done. It's a longer and more complicated procedure. It prolongs the cold ischemia time in deceased donor transplant. There's a higher blood transfusion requirement. There's no difference in allograft function if this can be done, and does lead to higher patient satisfaction with only one procedure and shorter cumulative length of hospital stay. What many centers do, including my own, a so-called deferred nephrectomy. So do the transplant, allow stabilization and reduction of immunosuppression, typically by 3 to 6 months, but it does require an additional surgery, which is typically a hand-assisted laparoscopic nephrectomy. So try to summarize the basic optimized measures for ADPKD management. So we'll go through our quizzes now. So dietary sodium intake should be reduced to reduced rate of TKV enlargement, decreased likelihood of nephrolithiasis, improved blood pressure control, lessen the fluid requirement to maintain reduced urine osmolality, or all of the above. Great. So as Dr. Watnick said, you're all paying attention. Okay. So optimized ADPKD management should be initiated when GFR is less than 60 mLs per minute per 1.73 squared, only when blood pressure is found to be elevated in all patients, when Mayo imaging classification suggests, sorry for the typo, increased risk of progression, that is 1C, 1D, and 1E, and when family history demonstrates ESRD below the age of 55. Yes, you want to implement optimized management in everybody because you want to slow the growth of kidneys, maintain cardiovascular health, and have the best long-term outcomes, even though progression may be slow. Thank you very much for your attention.
Thank you, Ron.
Thank you.